So, welcome to today's session, and thank you, friends, for joining. I now invite Dr. Juhi, professor in pharmacology at Himalayan Institute of Medical Sciences, to moderate the session. Over to you, Juhi.
Thank you so much, sir. It's my good evening, everyone. It's my absolute privilege to be part of this oration being hosted by MU India. This is a brainchild of Dr. Tejinder Singh, sir. And every year, uh, the Rita Sood oration is hosted through MU India. And there are monthly seminars which are hosted in reference to medical education. I'll just tell you a bit about the Rita Sood oration. Rita Sood oration, as we know, that is in the name of Dr. Rita Sood. She has been one of the finest clinicians that we know of. And along with that, she believed intensely in medical education. Having done her MBBS and post-graduation from Lady Hardinge Medical College, she later on joined full-fledged faculty at AIIMS New Delhi and later on headed the Department of Medicine at AIIMS New Delhi. She is one of the founders of founder president for Association of Health Professionals Educators, which hosts a national conference each year, NCHPE, and it is her hard work and inspiration that continues to guide us every time, each day, because she is one person who truly believed in student feedback. She believed in collaborative patient management. And today we remember her as we proceed towards the oration. Now, let me take the opportunity of introducing and welcoming Dr. Ashok Deorari, sir. Dr. Ashok Deorari is currently the Pro Vice Chancellor of Swami Rama Himalayan University at Jolly Grant, Dehradun. Formerly, he has been the Dean cum Principal at Jolly Grant Himalayan Institute, Uttarakhand. Dr. Ashok Deorari it's very difficult to describe him because his CV, if we talk about his CV, it spans pages and it spans years of experience. He is a man who often refuses to share his CV because he says that his CV is still building up. And let me know that Dr. Deorari is a leader with a difference. He has led multiple teams involving nursing students, nursing faculty, medical students, medical faculty. And he believes in the research which is visible, the research that can take you further and bring some benefit to the society, which is obviously visible. So the depth and width of his experience is something that we are really looking forward to hearing today. He has been the former head of the Department of Pediatrics, WHO Collaborating Center at AIIMS New Delhi, and a well-known neonatologist that we are all very familiar with. Dr. Ashok Deorari has, the screen is not moving. I'll just see if it can. Besides that, Dr. Deorari has been the past president of NNF. He has led various.
The screen is not moving.
The screen is not moving. Okay. Now, He has been the institute body member at AIMS Kalyani, currently at AIMS Kalyani and PGI Chandigarh. Dr. Deorari, when we were not very much talking about simulation centers in India, he was heading and he was the chairman of simulation center at AIMS. In fact, he was one of the pioneers of simulation at that time in 2017. And he also laid the foundation of simulation center at Himalayan Institute of Medical Sciences near Dehradun. He has been the lead for QI. He truly believes in quality education, and he has led WHO CRO countries and spread the message of quality improvement across the globe. He is currently the member of Every Woman, Every Newborn, Everywhere. This is a global initiative where they believe that along with the newborn, if you take care of the mother, a more comprehensive health care will come up. He is a member. He has been the member of Technical Advisory Group, Ministry of Health and Family Welfare for Newborn Care. He's been the short-term consultant with WHO, UNICEF, UNDP, UNOPS, name them, and Dr. Deorari would be there. He rose to the need of the country when we were struck by COVID, and the Prime Minister nominated him to Group 3 of COVID, where he helped capacity building, bringing together nurses and clinicians to rise to the need of the epidemic. He has been the co-director of ROP Task Force, Ministry of Health and Family Welfare from 2016-19, and a president of the NNF in 2020. Besides that, he has numerous achievements to his credit. He has developed training tools, modules for nurses, doctors, e-learning. He's a true believer in technological advancement, and he believes that we have to move with times. Otherwise, we would lag behind. So he has developed courses on ventilation, CPAP, and there are numerous publications which speak of his great achievements. He's brought in multiple grants with more than 300 publications with an H index of 64 and more than 11,000 citations. Dr. Deorari has been phenomenally involved with improving the state of art, bringing up state of art NICU. He has been working towards training the postgraduates as well as fellows at AIMS Delhi. He has received multiple orations awards, and he has been the visiting professor to multiple universities. I must tell you that we are very fortunate to have him here today amongst us, because there is so much about him that it cannot be contained in the small slides, and that is why we request Dr. Deorari sir to share the story of his experiences, because each of his experience will bring up a lot of learning and motivation to all the people who are here with us. So I welcome once again all the people from here, India and abroad, who have joined us, and Dr. Ashok Deorari sir. Sir, please, we request you to take the screen. Over to you, sir.
Can I share my slides? Juhi, you have to.
Sir, yes.
You may share the screen, sir. We can see the screen, the slides.
So good evening to all those who have joined for Dr. Rita Sood Memorial Oration for this year. I bring greetings from Swami Rama Himalayan University, Jolly Grant. And I am grateful to Dr. Tejinder Singh and Dr. Sanjay Bedi for giving me the honor of giving Rita Sood Memorial Oration for this year. I have known Dr. Rita Sood while she was at All India Institute of Medical Sciences. And the way she was involved in medical education, she was a astute clinician in Department of Medicine. And I often used to go to her office to discuss about what education plan Department of Pediatrics in Division of Neonatology is pursuing in the country and in the CRO region. She used to give me a lot of good inputs on how to go with teaching learning methods. She was like an elder sister to me. I have been pediatrician to both her children. And I am so honored that today I am going to give the oration on name of Dr. Rita Sood. So what I am going to share with all of you is this story of teamwork of nurses and pediatricians and neonatologists, how they have taken healthcare education to masses, not only in the hospitals, but to the peripheral small hospitals and even in the community hospital. The learnings from newborn babies, which we have treated at hospitals, have been the source of inspiration for us that we need to move education to the frontline health workers at remote places, because majority of the babies and the mothers are cared by health professionals who are working at the peripheral places. So I am going to focus on how we moved in the last 3 decades supporting health education, especially for nurses, then harnessing digital technology with innovative approaches to reach far and wide, not only in India, but in Asia. And then the different methods which we used and for diffusion and dissemination of best practices for healthcare professionals. Then realizing that whatever we want to educate people, and even if we want to make people competent, unless these are applied to the patient at the bedside, we will not get what the knowledge translation has to do. So for that, we started doing quality improvement methodology, which is implementation science. And then I would say a few words about future directions where we have to move with healthcare education at this point of time in the country. This is way back in 1989 and 90. We used to teach our undergraduate medical students in the 3rd year, and even the BSc students who were doing BSc nursing using simulators for newborn resuscitation. These simulators were high fidelity simulators, which used to have the lights, which used to show us whether we are doing cardiac compression in the right manner, or we are doing bag and mask ventilation for expanding the lung of the baby. These mannequins and intubation heads, we were lucky that we got through donation from American Academy of Pediatrics, which we were able to donate to the medical college. And then also by writing grants through Lardell Foundation, we were able to procure more mannequins and more intubation heads, which we distributed to a lot of medical colleges and nursing medical colleges. It became a part of the curriculum for UG students for BSc nursing and MBBS UG students in many medical colleges that they started teaching in small groups using simulators, newborn resuscitation. We were able to create a medical college network along with the nurses, and we were able to show the impact that we were able to reduce the asphyxia-related mortality rates in medical colleges through the network, which was of 14 medical colleges. And we published that in Annals of Tropical Pediatrics. In the year 1995 and 96, while I was the secretary of National Neonatal Forum of India, with the experts and reviewer neonatologists, we for the first time created standardized teaching aids in the form of PowerPoint slides and scripts which have to be taught to the UG students, the nursing students and the medical students. And these were freely available in the form of DVD, or they were put on the website for free download from AIMS WHOCC, Newborn WHOCC website. In the year 1995, while doing postdoctoral fellowship at Foothills Hospital, Calgary, Canada, and then working as specialist doctor at Kuwait Oil Company in 1997 and 2000, what I noticed was that in the field of neonatology, unless we empower our nurses or our nurses are competent, we will not be able to provide good care to the babies. In these hospitals, in the Western countries, and even in Kuwait, all the NICUs were managed by the competent staff nurses. So while I used to work at AIMS, I had a strong belief that unless we do something about nursing education and empower them and make them skilled and competent as co-workers with the neonatologists, we will not be able to provide quality healthcare. From the year 1999 to 2001, I was involved as a temporary consultant for WHO CRO for spreading IMCI training, Integrated Management of Childhood Illness Training. We used to do training of trainers in Southeast Asia region, in many of the countries, and in India. And then while doing that for 2 years, one thought came to my mind while I was doing training in Kathmandu, Nepal, which was for the nurses and the health workers and the doctors, the training was happening. That it came to my mind that the training of IMCI is so good. It is based on adult learning principles. We are training health workers and doctors in CRO region, but look back in your country, why can't you do similar type of teaching learning for the nurses who are working in the NICUs? And that made a change in my mindset. And what I did was I stopped altogether going for WHO consultancy for training of IMCI and decided that we will create a newborn nursing education program which will be based on the same teaching learning methodology as the IMCI methods are. And then we were lucky to get the support from Saving Newborn Life, Save Children for 2 years. And we were able to create a teaching learning tool for the nurses who were working in the healthcare facilities in the form of just like a IMCI training. For doing this, for tool development process, first what we did was in the year 1998 and 99, we did a focus group discussion. I did identify the course content, packaged that into a learning resource material. We pilot tested, field tested in 3 places, Indore, Dhaka, and Jaipur. And then we started doing training of trainers in different places and then spread in the state of Gujarat, to all the nursing colleges, and that led to creation of this training tool. And the contents of training tool were, as discussed, by need assessment and focus group. The contents were care at birth, basic resuscitation, thermal protection, kangaroo mother care, breastfeeding, prevention of infection and common procedures, and management of normal and at-risk and sick newborn. And the training methods which were used for teaching learning, which was spread over a period of 3 days, was self-reading with self-evaluation, demonstration, role play with oral drills, videos, frequently asked questions, group discussion, and skill learning, which was on actual clinical patients. With this package, which was called as newborn nursing package for facility-based care, the methodology, as I said, was in the form of small groups. And what we used modern educational methods of teaching learning. And then we also used low-cost simulators for teaching learning of these contents. And these were available in the form of a print, web, DVD, and smartphone apps. Simultaneously, in the year 2009 and 10, our students who were doing MD pediatrics at AIIMS, they started creating webinars and audio-visual podcasts for the equipments. And then with the experts from the country, we also started creating webinars on essential newborn care. With these, we had a vibrant website. We were able to load all these contents on the website so that these are freely available to people in India and outside India. Then in the year 2011 and 12, we thought of harnessing digital technology and innovative approaches for teaching learning. And to tell you the story, this is a real story which led to the development of a learning management system, which is called as a Moodle platform for India. This was in the year 2011 that there was a program which was being run by Southampton University, UK, which was called as Neonatal Online Training and Education Program, NOTE program. They were doing beta testing of the program on the Moodle platform. They asked me to be one of the faculty members joining them. So I joined for the beta testing of the program. We nominated 26 students from AIIMS, PGI, Hyderabad, and JIPMER to undergo this course on the Moodle platform. And then at the end of the program, our students were able to complete the courses, which was the beta testing of the courses. After that, what happened? The Southampton University, Dr. Mike, wanted that we should spread this program to India. And then while I looked at the cost of the program, it used to be exorbitant cost, and the program was tailor-made for very high tertiary care units. So at that point of time, because their program was supported by Leonardo da Vinci Foundation, I requested him, can we tweak this program so that it is suitable for level 2 and 3 units in India? He said, Dr. Deorari, that is your problem. So at that point of time, what I decided was that we will create a learning management system on a Moodle platform for our own students in India and Southeast Asia region. And that led to the development of a program which is called as On Top program, online neonatal training orientation program. It is called Dash in India. So we created a website, the LMS on our own, because we learned while we were doing beta testing of the Moodle platform with the UK team how that platform can be created and how that is run, how the backend is going to be managed. And we created this platform on our own and then started using this in India. And through this platform, we created a network of teachers because the program used to run in cohorts for the student, 15 to 18 student with 2 teachers. And then we had facilitators who were not only from India, but they included from many of the Southeast Asia region country. And typically, while we were running this on-top program, the program used to run for 1 week. And then for each week, we had the course rubrics, which was predefined. And then it had learning objectives. And then it had, in addition to that, it had webinar, it had evidence-based protocols, it had videos, and then text. And then it used to be in the form of discussion forum and the chats, which were synchronous and asynchronous, which were on the same platform it was being run. And then the platform which was created at that point of time is still existing and running at this point of time with at least 1 to 2 courses every year. And you can see the courses which are running at this point of time this is the 23rd newborn care course. And in each course, nearly 150 to 200 students get enrolled and it is free of cost. And then there are teachers who run the different cohorts for different hospitals. And then even for nurses, this is being run. And we have team of wonderful facilitators who not only are neonatologists, well-reputed leaders, but even many of the nurses are part of the team who still are able to sustain it for years together, this platform. So while we were running this e-learning platform, at that point of time, I met 2 young students at AIMS, New Delhi. One of them is intern, Shiju Thomas, and the other is Rishiketan Sethi. He was 3rd year undergraduate medical student. And what they told me was, while we were running e-learning courses, that they are very proficient in making apps on mobile phone. And Shiju was very proficient in making apps on mobile phone on Android phone, while Rishiketan Sethi was very proficient in making it for iOS system. So we started creating apps on mobile phone to reach more and more healthcare professional through and the first app which was created was on standard treatment protocols, which were developed for WHO CRO by AIMS WHOCC in the year 2012 and 13. And for standard treatment protocol, we used to teach this using using wall charts, job aids, and these were in the form of flow algorithms which are there. And then again, these were taught to the student in small groups. And as I said, students created these apps on mobile phone, and the greatest advantage of these apps was that we were able to do a revision very quickly. We were able to bring out the new edition very quickly and then free of cost. But we had all the contents which were with us. These were all validated, beta tested, and we made sure that they will serve as point of care tool to healthcare professionals while they will start using these app on mobile phone. So here is one storyboard of one of the apps. The window of app shows you different conditions. Suppose the patient has hypoglycemia, sugar is less, you click it, it will ask you to show a protocol. based on the blood sugar level, what action has to be taken based on whether the baby has clinical symptoms or not. And then it moves to the next one. So basically, it was trying to provide a point of care tool for healthcare professionals. And these apps on mobile phone, while they were launched in the year 2014 and onwards, the download for these apps not only happened in India, but all across the globe in multiple number of, in thousands. And then in the year 2020, WHO, UNICEF, one of the documents mentioned that this is one of the catalyst innovation which has been done by All India Institute of Medical Sciences, the apps on mobile phone, the WHO CC, STPs, standard treatment protocols for Android, Sick Newborn Care app for iOS system. And then we also created apps for Helping Babies Survive program for American Academy of Pediatrics. And these were all available free of cost, not for the money. So working with the apps on mobile phones, especially for the WHO standard treatment protocols, later on, we also contributed with the ICMR for development of standard treatment workflow for newborn babies. And as you know, that standard treatment workflow of ICMR are created for nearly 28 specialties. And there are more than 150 standard treatment workflows. These are flow algorithms, and these are endorsed by India Country Office, WHO, National Health Authorities. And we were lucky that with me and Dr. Praveen Kumar from PGI Chandigarh, with 35 experts, we were able to create for at least 14 conditions in the newborn, the standard treatment workflow. Now, making guidelines, making apps on mobile phone, we wanted to make sure that they reach more and more people. We wanted to do better dissemination. So we had the opportunity of working and creating another package, which was for preterm babies, which was in the form of 10 modules. And then for each module, there was a lesson plan, learning objectives with videos and webinars, with job aids and text and assessment strategies for the healthcare professionals. And for this, we did expert and review group meetings. And then we had one student who was a student of DPS school, Vaishnavi Gupta. She said she can create a course for us, which can be on web-based platform, which will generate a certificate if the student is able to complete all the 10 modules and able to score more than 80% marks based on the assessment for each and every module. And if the student is not able to do the first module, he or she cannot move to the second module. And she was able to create this for us. And the content of this e-platform were in the form of 65 webinars, which were short and crisp, short webinars, short videos, which were 135 in numbers, and they were all packaged together. At the end, if the student is able to complete the course, the student gets a certificate like he or she has completed a facility-based care of preterm infant, eliminating retinopathy of prematurity. Self-generated certificate is generated out of this platform. And then we wanted that it is not only knowledge which is important, the students must have also learned the skills and the procedures, and there has to be a way by which the student has to be assessed. And then for that, we created a network of medical institutions where the students were shown the procedure. They were able to do it, and they were given the feedback, and then the assessment was done with the OSCE. So a combination of blended learning course was developed for preterm babies. And then we were able to spread that in the country far and wide in majority of the states through our network of NICUs, the neonatologists who were able to be with us together. And at this point of time, World Health Organization, WHO, was very generous. They were able to give us low-cost task trainers, which were called premenatally, neonatally, and mama breast. So we were able to donate that to all the medical colleges who were part of our network. And then in the year 2020, when COVID struck, we were able to do this e-course for preterm babies online and then using Telegram app. And then we were able to connect to nearly 4,600 nurses were all enrolled for this program. And this was done under the banner of National Neonatal Forum of India. And there were 70 facilitators. 7 facilitators were able to handle 1 week while the students used to interact with them. And this is the team of all the facilitators who were spread all across India. And then during the COVID time, we were also able to create webinars on sick newborn babies and webinars on essential newborn care for dissemination through our website, which is a vibrant website of WHO CC. Now, over the years then, while we were doing knowledge, imparting knowledge to our students and getting to different states, touching the district hospital, the SNCUs, doctors and nurses, what we found was the coverage of life-saving interventions is not enough. Evidence-based best practices don't reach, they don't get translated for the patient care. And we wanted that they must reach all, and they also must reduce out-of-pocket expenses. And for that, we started by chance. We had the opportunity of learning and spreading quality improvement methodology, which is the implementation science. And for this, which is called as a point of care quality improvement methodology, it is a very simple method of teaching and training how to fix the gaps for the implementation. That means if you are not able to translate a best practice, and how do you fix that gap and make sure that it gets translated? And for doing that, you have to do measurement of the process and the outcome. And for this, we created a simplified and demystified training tool, which is called as the point of care quality improvement tool. And this tool uses a 4-step approach that first you identify what the problem is, you form a team, and then you write a aim statement, first identifying and prioritizing what problem you want to solve in step 1. And in step 2, you analyze the problem, do a root cause analysis of the problem, and try to find out how you are going to measure the quality of care by either looking at the process or the outcome indicator. And for analyzing the problem, 4 tools, common tools, which are used are 5 whys, flow algorithm, rule of Pareto, or a fishbone analysis. And then you need to identify for the process and the outcome, what is the numerator, what is the denominator, and then create run chart, which is the XY series chart. X is the time, Y is for the process and the outcome indicators. You make the run chart or a control chart. And then you find out the change idea which you want to test on a small number of cases. So that is done by PDSA cycles, plan, do, study, act cycle. And then based on what is working, either you adopt it, or you adapt it, or you abandon the change. And then based on what improvement you are doing, you keep on making improvement and sustain it over some duration. For creation of quality improvement tool, I think it was just by chance. In one of the Independence Day celebrations, our director, Professor MC Mishra, then director in 2015, he made an announcement that very soon, Division of Neonatology, Department of Pediatrics will take a lead and start doing quality improvement work at All India Institute of Medical Sciences, New Delhi. So that was a surprise to us. And then we thought this is a good opportunity that we want to do quality improvement at AIMS through our nurses, our resident doctors, and the faculty members. And then in one of the Institute Day functions in 2016, then our Honorable Health Minister visited and met our team, which was doing quality improvement methodology at AIMS, New Delhi. And here you can see Professor MC Mishra, who is standing for the quality improvement workshops, which were regularly conducted at All India Institute of Medical Sciences. And then in 2016 and 17, we were able to do for 6 AIMS and Institute of Excellence, 3-month capacity building course on quality improvement with the help of US Aid Assist and Institute of Health Improvement, Cambridge, Boston. They came and it was a online and a physical mode 3-month training, and a lot of people did a lot of quality improvement projects, shared that, and the success story not only was confined to AIMS or to other AIMS, but it spread to Maldives. It also spread to Bhutan and nearby countries. And then here is one of the grand rounds which is happening for AIMS. And if you see just here on the right side, it is Dr. Rita Sood. She's sitting there listening to the grand round on quality improvement. She was very happy at that point of time that we have started doing something good for improving care at All India Institute of Medical Sciences. And in the front row, you can see in the quality improvement clinical grand round in 2017, our previous director, Professor Sneh Bhargav, and then we had MC Mishra, and at that point of time, Dr. Guleria had joined as director. That grand round happened on quality improvement work, which we wanted to share. So as I said, best practices which improve the outcome for sick and small preterm babies, especially in my field of neonatology, we were not able to implement that. And to implement that, we learned the quality improvement methodology. And then we were able to take this to the special care newborn units in the state of Madhya Pradesh. And then we were able to show that combining training package to improve the knowledge and skills of healthcare workers in managing sick and preterm babies with point of care quality improvement methodology, it reduced the unnecessary use of oxygen, antibiotics, and use of phototherapy in the SNCUs of Madhya Pradesh. And they were able to save money by saving less use of oxygen. So realizing that implementation of best practices often needs, we were able to do quality improvement work, but over the years, then in the last 2-3 years, what I have realized is that very often, while you want to make improvement, you also need health system strengthening in terms of manpower, in terms of supply chain, because unless these are also fixed, the healthcare professionals are not able to do the best for the patients they are caring for. Now, what next in healthcare education? To me, it looks that for medical colleges and institutions, we are going to see that we will be using virtual reality, augmented reality, and mixed reality in a big way for teaching learning of students. For patient care management, tele, tele ICU's concept will come. And for education, tele simulation will be the way forward. Gaming, robotics is going to come in a big way. Computer assisted surgery is going to come. Artificial intelligence is going to come in a big way. But the problem with newer ways of learning would be that by embracing these, we will not be able to teach soft skills, communication skill to our future generation of students. Also, we will have to keep in mind that whether these new ways of teaching learning of the student actually will make safe care or improve quality of care for the patients or not, we'll have to find out by doing research. One more thing which we'll have to keep in mind is these technology, which are inevitable, they come at a very high cost. Because majority of the technology of AR, VR, and mixed reality, they work in silos. They work on cloud, and their devices or hardware don't sync with each other. So the cost is going to be a major factor while we adopt these technologies which are going to come from outside. So what we have to make sure is in a country like India, which is vast, where the need is going to be enormous, we have to somehow innovate and to make in India, for India, and then for global use. That concept has to be there, and we must make sure our resources are cost effectively utilized if we want to use these technologies. If we try to buy this from Western country, is going to cost very high cost for on us, especially in terms of resources for doing education in the current times or in the future times. So in medical college and institution, I see this is going to come over next few years, and we will have to find out a way how we can save our resources. The second thing which is also in front of us is that our district hospital and nursing homes, where vast majority of the things can be prevented, we must make sure that we are able to provide basic care. And if we want to educate our healthcare professionals who are maybe the ANMs or the nurses there, again, we have to use the similar teaching learning method as we use in medical colleges. It has to be, again, based on simulation-based teaching learning, case-based scenarios, and small group teaching learning, and use them in a way so that we are able to prevent majority of the complications, because the patients land in medical colleges many times with complications because of lack of basic care which is not getting provided. And for doing this, to me, it looks like a program which is propagated by World Health Organization for newborn babies and mothers, like the Essential Newborn Care Program 1 and Essential Newborn Care Program 2. basically one program is helping babies breathe, which is just like teaching basic resuscitation, and the program Essential Newborn Care Program 2 is a program which is essential newborn care, as we were doing for the nursing, but it is in the form of a wall chart, made much more simple. And because I am part of these programs, so I feel this is going to be the need for us. And then the standard treatment workflow, which are made by ICMR, these can be tailor-made in the form of modular-based teaching learning, which can be given to the nurses and doctors who are working in the district and small hospital. So this is what I see in future times, that how the education can get to the last mile. So in closing, I would say my message for young students is that the younger generation, that yes, you read from the books, master your science, treasure your knowledge, but remember this, your real lessons will come when you listen to your patient or work in the community, when you serve with humility, especially for poor who are there in the small hospitals. These are unwritten chapters of education for younger generation. And in closing, friends, to me, books gave me knowledge, but the real world beyond books gave me wisdom. Let us keep learning not only from books, but from the real world where you need healthcare translation to happen. Thank you so much. Thank you.
Thank you, Deorari sir. It's been a pleasure listening to you, and it takes the magnanimity of heart to share our own stories. Only when we have lived them well can we share them with such ease and conviction. I'm sure your stories will they will inspire a millions, and the young generation is always ready to harness all that is coming up new. So we wish that you publish these stories tomorrow into a book. Wishing you all the best, sir. I now hand over the day to Dr. Sanjay Bedi, sir. Thank you so much.
Thank you, sir. It was really a pleasure listening to you. In fact, I have seen your journey since 1990, and I feel, on behalf of MU India, we feel honored in giving you this Rita Sood Memorial Oration, and along with that, uh, uh, the Lifetime Achievement Award for such a long journey which you have taken, and it is still continuing at quite a speed. I think when India achieves its 2047, the status of a developed nation, your contributions will be enormous towards that achievement. Thank you very much, sir.
Thank you. Thank you, sir. Thank you.
With this, we end today's session.
Thank you, sir. Thank you so much. Thank you for the
sir.
opportunity to share.
Thank you, everyone, and congratulations once again, sir.